I'm going to start off by making a few introductory comments and briefing about the state of both our hospitals at St. John and here in Vancouver, and then talk a little bit about what we're expecting in terms of preparations to receive the COVID-19 vaccine, and then open it up for questions. In terms of our current COVID status, we have 42 patients in-house at our Vancouver, PeaceHealth Vancouver facility. 4 of those are ICU patients, and the remainder are either medical surgery or what we call step down. So they are intermediate between ICU and regular med-surg status patients. We do have the capacity to take up to 54 COVID patients in our current configuration. And what I mean by that is we have walled off areas of the hospital to keep our COVID patients very safe and other patients very safe. And we have the ability within those existing spaces to take up to another 12 or so. And then we would have to construct more space within the hospital for additional patients. And we can usually put up a wall that's ready for additional patients within about 24 to 48 hours maximum, and are prepared to do so if we need to. At our St. John facility in Longview, we historically have not, during this pandemic, been admitting COVID patients as inpatients. We have been treating quite a few of them in our emergency department, and then moving them to our Southwest campus, where we've been cohorting our COVID patients. Due to the increase in the number of COVID patients in our communities, however, we've made the decision to stand up a COVID unit at St. John, and that should be in place by Thursday. The final plans about the initial census and volume of folks that we can take in that campus are still being developed, but around approximately 10 patients at St. John. Our hospital capacity, thankfully, at both hospitals, both for non-COVID patients and COVID patients, is in reasonable shape. Just as an example, right now we have 285 total inpatients, including COVID patients, at our Southwest campus in Vancouver, and we can go up to about 340 before we max out. So we are doing fine in terms of capacity. However, as I think everyone on this media briefing today knows, we are concerned, as are many public health officials, that we may see a pretty significant increase in the number of COVID patients in our communities over the next 2 to 4 weeks in particular. And we are doing surge planning in relationship to that to be ready should that surge materialize. And we're predicting a surge, unfortunately, of somewhere between 20 and 40% as being possible, looking at transmission rates in our communities, and if the sort of the post-Thanksgiving surge comes to fruition as we think it might. So the surge planning includes a number of things that I'll just briefly mention. One is additional hospital space in both hospitals and contingency plans to open up additional space. We also are bringing on more nursing and other staff to get ready. And then we have instituted contingency plannings for our physicians, particularly our frontline physicians who help with our COVID patients. So for example, our intensivists, our ICU doctors, play a really key role in taking care of these patients. And they were asked by me to create levels of redundancy so that if, God forbid, one of them became ill or their family member became ill with COVID, that we would have the ability to backfill their position with other qualified physicians in order to keep care going. Same with our emergency department doctors, who obviously are playing a really instrumental role in taking care of these patients. Our PPE supply, fortunately, remains good. We are in the green, which means that we have high confidence of getting through the winter months with ongoing PPE replenishments, but also our current supply. As I mentioned before, we are preparing to receive the COVID-19 vaccine. We are one of the staging hospitals at PeaceHealth Southwest that's been identified by Washington State for receiving the vaccine once it's available. It looks like right now that maybe as early as 2 to 3 weeks from today. And if we did, it would likely be the Pfizer product first, and then followed perhaps a week later by the Moderna vaccine product. A lot of work has gone into getting ready and continues to go into getting ready for vaccinating a wide number of people quickly with the vaccine. We won't be requiring vaccination of our healthcare workers, but we'll be strongly recommending it, particularly after it's vetted thoroughly by the FDA, by a national group that looks at vaccine safety. And then the Western states have made a pact to have their own experts also review the safety and efficacy data for the COVID vaccine. So once that's completed, and that's set up to be done very quickly, as soon as the vaccine is authorized, we would start vaccinating, and we would likely target initially our caregivers who are on the front lines, most likely to come into contact with COVID, because we really got to keep them healthy so they can take care of others. So definitely more to say about each of these topics, but I will stop here and invite questions.
So I wanted to ask you a little bit about flu. I know that the state is saying numbers are remaining fairly low compared to what we've seen in previous years. I'm curious what you guys are seeing about that. If you have any theories, I'd be curious to hear why you think the flu hasn't emerged as we thought it might. And just how much does that concern you in terms of if we start to see flu getting out in the community and people showing up at hospitals and adding to that part of the strain on your capacity? Can you just talk a little bit to how you're preparing for that and what you're seeing in terms of the flu in your hospitals?
Thank you, Chris. So we have seen our first case within the PeaceHealth system. I think we're getting some echo, Randy.
That's from me.
We have seen our first case of somebody co-infected with flu and COVID-19, which was one of the fears that we have had all along. We haven't seen subsequent patients yet with both of them. But to your excellent question, I think one of the things that we're really worried about as physicians and healthcare providers is if we do have even our normal amount of flu coming into the hospital, it's easy if the community prevalence of COVID also rises to overwhelm healthcare systems. We, like I said, have done a lot of preparation to make sure that that doesn't happen. But speaking more broadly than PeaceHealth at the moment, um, we are strongly urging everyone who possibly can to get your flu vaccine this year. Even if you don't typically get the flu vaccine, this is a particularly important year to get it. And the reason, again, is a small percentage of people with the flu go on to need hospitalization. And we know, for example, what the percentage of people who get COVID who go on to need hospitalization. And if those two add together and combine to produce hospitalizations beyond what our communities can tolerate, we will be in a place that I think none of us wants to contemplate. And again, we've done a lot of work to make sure that that doesn't happen and that we are in the best place possible. But I'm really asking for the public's help in doing this because we need to be able to have adequate space in our emergency departments and our inpatient wards and our ICUs, across the state, so that we can take care of both people with COVID, but also people coming in with more, if I can put it this way, more regular stuff like strokes and heart attacks and pneumonias and things like that. So thank you for the question.
If I could ask one quick follow-up question on that. You mentioned that you've seen your first co-infection. Can you speak a little bit about what you see in those cases and what is your concern in terms of could that increase the mortality rate of COVID-19? Obviously, that's still going to be an emerging situation if we start to see more of these cases. But given what we know about how these impact the body, what's the concern for somebody who potentially gets co-infected with both?
Yeah, so two points. One, we haven't seen enough cases to know how folks are going to respond to getting both, and hopefully it's a very rare event, but we again, it's too early to know. But theoretically, it is concerning because you do have two different viruses that attack the body in very different ways, and they can both affect some of the same systems. So to your point, they can often both affect breathing and the respiratory system. And when you've got two different ways and two different viruses that are doing that, theoretically, the virus has a lot more to fight off. And you could see patients that are much more ill than having either one alone. The other danger is that they both activate the immune system, so our ability to fight off these viruses in slightly different ways. And what may be beneficial for treating one of them may be a little bit less beneficial for treating the other condition. And it may complicate our ability to effectively treat these when you've got both of them. For example, a drug that may really benefit someone with COVID may actually worsen the condition of someone who's got, influenza or flu. Hi, Kendra.
Hi, Kendra Kent here from KPTV. I have two questions, if I may, and I would like to just start with, could you get me up to speed on elective surgeries and if there are any plans to change how you're doing those at this time?
Thank you. Great question. So right now we are not doing elective surgeries in the sense that we are using a 90-day horizon to bring surgeries into both St. John and PeaceHealth Southwest. What I mean by that is the surgeon, in collaboration with the patient, does an assessment of the need for surgery and the likelihood that that patient, that particular person, will worsen in the next 90 days. And if it seems likely that delaying the surgery will cause worsening within that 3-month time horizon, we do have the ability at both our campuses now to go ahead and do the surgery. And that is frankly because of a lot of good luck and preparation as it relates to having adequate PPE and adequate hospital space and staffing at present. We do have a very sophisticated plan in place to be able to calibrate downward on our surgeries still further if we needed to accommodate additional patients and additional COVID patients. So our surgeon leadership and our surgeon senior physicians have made plans to categorize different types of surgery in terms of how important they are that they go forward in 90 days, in 30 days, in 24 to 48 hours, and have the ability to turn off the surgeries as we need to make sure that we've got space for other patients and for our COVID patients. We look every morning at 10 a.m. at a prognostication tool, a prediction tool that allows us to see if the number of surgeries matches the number of inpatient beds plus a significant buffer of patients that we have so that we feel safe and comfortable with going ahead with surgeries.
Okay, thank you. And then my second final question. I've heard a lot of anecdotal stories lately about frontline healthcare workers trying to get out of the clinical setting or perhaps even leaving the industry altogether. Maybe it's related to fatigue because of how long these frontline workers have been dealing with COVID-19. You mentioned bringing on more nursing staff and more hospital staff. Has it been tough to recruit people in this area or to your hospitals? Are you noticing anything with that?
Thank you. Great question. So we haven't noticed that yet. I hear from colleagues of mine across the country that they are really struggling to recruit nurses and others, and that using temporary nurses, for example, has become increasingly expensive across the country. Thankfully, we're not seeing that at PeaceHealth at this point in time. Early in the pandemic, we did offer the opportunity for folks to take early retirement, things like that, as a purely voluntary option. We did have several dozen across the PeaceHealth system take us up on that. But subsequently, as we've seen our surgeries come back and the number of COVID patients continue to rise, we have been increasing the number of nursing staff that we have available. And so far, cross fingers, haven't had any difficulty recruiting them to us. And I think part of that is that they know that we have the right PPE to keep them safe. And I think that's very reassuring in this time. And I think part of that is that they know, and we really make clear that we will do everything possible to make sure that they don't experience the burnout that you hear reported nationally in some hospitals that have been more affected. So as an example, nurses who work in our COVID units, who really are the heroes of this story and are taking the lion's share of the compassion and the small amount of risk, but nevertheless some real risk of taking care of COVID patients. They're doing so heroically, and we do give them, for example, extra long lunch breaks, which doesn't sound like a lot, but when you're doing work wearing PPE and you know you have to be careful all day long to keep your PPE in place, it's nice to have a break from doing that.
Yeah, hi, doctor. Thanks for doing this. We appreciate your insight into all this. I just wanted to follow up on the 40%. You said 20 to 40% is kind of what you're expecting from this Thanksgiving-related surge looking forward a few weeks. Where does that put your hospital? If it were to be, say, worst-case scenario, and you're at 40%, what would the capacity look like in your hospitals?
So if it did, if we did see sort of worst case scenario with 40% increase in the number of COVID patients, we would be able to handle those patients. We have a lot of expertise developed now with treating COVID-19 patients with sort of cutting edge medical interventions. And it would be a strain, particularly a strain on our nurses and physicians and respiratory therapists and physical therapists and everyone else who plays a role in this. The way that we would address that strain would be to start titrating back on surgeries and other procedures that we can safely put off. And that would free up beds, nursing staff, and physicians to help backfill. We would make it through it. We are going to make it through this, but it would be an uncomfortable number of months.
Yeah, and as a follow-up to that, quickly, are you coordinating things with the hospitals across the river in Oregon who are facing the same thing?
We are coordinating both in sort of Washington State as a whole through the organization that brings Washington State hospitals together, and with our Portland area hospitals. And there is a regional program, for example, that goes into effect to help us coordinate if there's a massive surge where COVID-19 patients would go, into which hospital, who would have the capacity to take them, that kind of thing.